I want you to know what a general practitioner should know from toxicology. Like, what are they supposed to know? How are they supposed to approach the patients who are suspected to have ingested or got exposed to a toxin? Uh, when you're studying cardiology, you're not supposed to know what um, the complications of cardiac transplants are. But you're supposed to know the basics of approaching patients with chest pain, how to manage it, how to manage an MI. The same thing applies to toxicology. We're not going to talk about the weird and wonderful stuff. We're going to talk about common and common approach and common toxins. It's almost 10:10. We have 20 participants, so probably just 10 are missing. All right. So the objectives, you probably got these objectives from your school. So we're going to just have a short introduction. We're going to speak about pharmacokinetics and toxicokinetics. I don't want you to go into the details of that. I just want you to understand the difference between the two. And then we'll talk about common signs and symptoms, or what we call toxidromes. And then the basic management skills. What investigations we need to do when we are seeing a patient with suspected intoxication or overdose. Indications and contraindications for decontamination techniques, and we'll talk about what decontamination is, and then we'll speak shortly about common antidotes. Okay, so this is a comment say by Paracelsus, and it applies to everything. So poison is in everything, and nothing is without a poison. The dose makes it either a poison or a remedy. So all the medication that we use them in therapeutic doses. We can see side effects, but we don't see poisoning from them. But if you take an overdose or you take more than what you're supposed to take, then we start seeing the complications of poisoning. The best example is paracetamol. We use it a lot, and most patients do fine with it. But when someone overdose on it, they go into liver failure, and sometimes they die. So even water, if you take too much water, then you might get hyponatremia and get seizure and get other complications. So it's important to know the dosing of your medications before prescribing them. All right. So what's pharmacokinetics and what toxicokinetics? You probably studied in pharmacology the pharmacokinetics, and the simple way of describing it is what the body does to the drug. I take a medication or a drug, and then the body handles the drug from absorption, distribution. Someone is trying to talk, or okay. From absorption to distribution to metabolism, and then elimination and getting rid of that toxin or medication. So that's when we take the medication in therapeutic doses, that's pharmacokinetics. When we take it in overdose, that's toxicokinetics. And why do we care? Is it different? Yes, it is different, and that's why we call it toxicokinetics, because when you take a huge amount of drug, if you look at the picture there, the x-ray, you see multiple tablets forming a bezoar in the stomach. This will alter the absorption of this medication, and this will result in delayed absorption, delayed effect, delayed toxicity, and so on. And that's why it's different between pharmacokinetics and toxicokinetics. In distribution, it's different because when we take drugs at therapeutic doses, they're bind to plasma protein, and in only small amount is free to act. While when you take it in overdose, there is a lot of free drugs that's not bound to plasma protein and can cause toxic effects. And metabolism is the same thing. When you saturate the metabolism with so much of the drug, the metabolism get altered, either prolonged metabolism of the drug or other pathways get activated and toxic metabolites results. And we'll see an example of that in paracetamol. And then elimination. Also, when you take a huge amount, the excretion of the drugs takes longer time. And even the part of the elimination is through metabolizing the drug to non-toxic metabolites. So this can take longer time, and then it takes longer time to get rid of the drug. And sometimes actually we cannot eliminate it because the toxin causes renal failure, and then you cannot eliminate the toxin. So that's why there is difference between toxicokinetics and pharmacokinetics, okay? In general, it's what the body does to the toxin or drug. It's absorption, distribution, metabolism, and elimination or excretion. Excretion is part of elimination. All right. So pharmacodynamic, on the other hand, is what the substance or the toxin does to the body. Xenobiotic is any substance that's foreign to the body. So if someone takes a beta blocker, then what happens is usually we give it to slow the heart rate, right? So that's the pharmacodynamic effect. It's the effect on the receptor usually, or the action of the receptor, or the channel that we're like a calcium channel blocker, or a sodium channel blocker for seizure, for example. So it's the act on the receptor or the ligand. So that's the pharmacodynamic. This also gets affected when you take a huge dose, and that's why we call it toxicodynamic. If you take more than the therapeutic dose, then in some drugs you will get extension of the pharmacological effect, like beta blockers. They will cause bradycardia, but if you take overdose, you may get a heart rate of 30, 20, and then cardiac arrest. So that's an extension of the pharmacological action. Sometimes it's not an extension of pharmacological action. You get an extra action. Like, for example, olanzapine, which is a dopamine blocker. When you take it in an overdose, it blocks the alpha receptors and you get hypotension. So that's not a pharmacological effect. That's not a pharmacodynamic effect. It's a toxicodynamic effect. Sorry?
في طلاب يحترونك توافق تدخلهم بس.
Oh, sorry. I'm not used to this. Just give me a second. Participants. Thank you for alerting me. Okay, so I probably keep this open here. Okay, so we said we're gonna talk about the approach to the poison patients, and we started talking about pharmacokinetics, toxicokinetics. So pharmacokinetics is what the body does to the drug at therapeutic doses. Toxicokinetics is what the body does to the drug in toxic doses. Pharmacodynamic is what the drug does to the body in pharmacological doses and in therapeutic doses. And toxicokinetics is what the drug does to the body in overdose. So we give an example. And the other example is the antihistamines. If you take antihistamines in usual therapeutic doses, you usually get the therapeutic effect of stabilizing the mast cells, maybe some sedation. But if you take too much of antihistamines, even selective antihistamines that's supposed not to cause sedation will cause sedation. So you lose the selectivity in overdose. Beta blockers that are selective on beta-1 will lose selectivity in overdose. So that's why we call it toxicodynamic. So the difference between the dose makes a difference on the effect. All right. I just want you to understand the concept. You don't have to worry about the details. Okay. So toxidromes, this is very, very, very important for you guys. Because you're going to see patients, they're not going to be able to tell you what they took because they might be altered, or they maybe they don't want to say what they took. So that's why you need to recognize these toxidromes, and then you can manage based on these toxidromes. Someone who's raising his hand, Muhammad Hussein. Yes. Okay. All right, so it's very important that you recognize these. And what we mean by toxidromes, these are signs and symptoms that will guide you to the substance that the patient took, whether a medication or a toxin, okay? And we have several toxidromes. We have anticholinergic, cholinergic toxidromes, sympathomimetics, opioids, serotonin, and sedative-hypnotic toxidromes. We'll speak about every one in details. So, All right. So we'll start with the anticholinergic toxidrome. This is actually quite common everywhere because so many medications, especially the antihistamines, they do cause anticholinergic toxidrome. And how does the patient present when they have anticholinergic toxidrome? Do you guys know? It's what you see in front of you. I'll just keep going. So they usually come altered, or maybe early on they might not be altered, but they will be tachycardiac. They have dilated pupils. That's why they cannot see very well. They have mydriasis, and then they have red, hot, flushed, but dry skin. Okay. And they might be having hallucinations. They see small things in the air and they try to catch things that doesn't exist. So tachycardia, dilated pupils, red, dry skin. It might not be red, but it can be red, but it's very dry. That's the classic feature of it. And the difference between the anticholinergic and sympathomimetic toxidrome, does someone know? You guys know? Sympathomimetics versus anticholinergic. So the difference is anticholinergics, or the patients will be very dry. In sympathomimetic, they will have sweating. This is the best feature to differentiate the two. The sympathomimetic will have a perfused sweating. So I just give you an example here. That's what you're going to see mostly is the antihistamines. You can see the anticholinergic effect with antidepressants and with antipsychotics as well. And you can see it with some plant. This plant here is هذه في السعودية في الشمال يسموها السيكران. It causes anticholinergic effect. يوازيها في الدول الثانية دول الأوروبية ونورث أمريكا الداتورة أو الجيمسون ويد. Okay, so you need to know the features of each toxidrome because it's very important clinically, and you will manage according to their clinical features. So when you see something like an anticholinergic toxidrome, how do you treat it? So mostly supportive care. The antidote visostigmine, we used to avoid it altogether because there was cases of cardiac arrest after giving visostigmine. But these cases were for patients who had TCA overdose and they came very late. So visostigmine is okay, but I think if you want to use it, you should contact the poison center and get the toxicologist advice whether you can use it or not. And at least get an ECG and make sure that you don't have a wide QRS and signs of TCA overdose. Usually supportive care is enough. You cool them, you give them fluids, you treat them with benzodiazepines if they are agitated, and they do fine. And again, here are the examples of the drugs that can cause anticholinergic toxicity. All right, just keep going. All right. How about cholinergic toxicity, the opposite to the one above? So we talked about the anticholinergic. We said tachycardia, dilated pupils, dry skin, and hallucinations. If you take cholinergics, the opposite, you're expected to have bradycardia, you're expected to have profuse sweating, secretions everywhere because your glands are stimulated. So you're going to have salivation, lacrimation, urination, defecation, and so on. That's the muscarinic effect of the cholinergic drugs. When you take organophosphate, you're going to have the nicotinic effect as well, which is weakness, vesiculation. They might go, because of the weakness, they might go into respiratory depression.
It's very red in my crotch.
Yes?
Yeah.
I can't hear you.
3, 2.
Okay. So That's cholinergic toxidrome. It's the opposite to sympathomimetic. You're gonna see it mostly في السعودية from organophosphates or carbamate. These are insecticides يستخدموها العلاج لقتل الحشرات خصوصا في المزارع. بعض الناس يستخدمونها في البيوت للأسف، وهي المفروض ما تستخدم في البيوت لأنها قاتلة. Okay. All right. So some medication can give you the effect, the cholinergic effect, which is like Alzheimer's medications because they directly stimulate acetylcholine receptors. Myasthenia gravis medications like pyridostigmine and visostigmine can give you cholinergic effect. And that's why we use visostigmine to treat anticholinergic effect. Okay. These medications have less severe effect than the organophosphate. This is a common organophosphate that's used in Saudi Arabia. The organophosphate acts actually not by stimulating the acetylcholine receptors. They actually act by inhibiting the degradation of acetylcholine. So you have so much acetylcholine that can act on the receptors and cause the symptoms. Okay. We said chemicals, organophosphates, and carbamate medications is these ones. The treatment of this is actually good supportive care. You protect their airway if they cannot protect their airway. You treat their hypotension if they're hypotensive. You give them oxygen if they're having low oxygen saturation or hypoxemia, and then you give them the antidote, which is atropine. Atropine is an anticholinergic. You see, when we talked about anticholinergics, we give cholinergic to treat it. When we talked about cholinergic toxidrome, we give anticholinergic to treat it. So we give atropine. We give atropine in big, big doses, not like what the cardiologists use for bradycardia. The cardiologist will start with 0.5 milligrams, 0.5 milligram. We start with 2 to 3 milligrams, and then we double the dose every 5 minutes until the secretions are dry, because these patients, they have a lot of secretions from their glands, including secretions in their lungs. So they drown with their secretions. Their lungs is full of fluid. They get hypoxia, and then they go into cardiac arrest. And that's why we give them atropine until we dry their secretion. And then we give them oximes, which is like pralidoxime is an example of the oximes that we use. But the most important and what's going to save the patient is atropine and good supportive care, which is intubation if they need intubation, fluids if they're hypotensive, and oxygen and so on. All right. Am I going? It's just because we wasted some time. I'm trying to go a bit faster. So this is the sympathomimetics toxidrome. And with sympathomimetics, you get what you see in the picture: dilated pupils, profuse sweating, hyperthermia, tachycardia, hypertension. They can get seizure, and they could die from this. An example of the sympathomimetics is cocaine, right? Amphetamines. Ventolin can cause sympathomimetic effect, not as bad as the drugs that I just talked about, but it can cause sympathomimetic effect similar to this, and not as strong as this one. Okay, it won't give you the sweating, but it'll give you the tachycardia, the dilated pupils, give you hypokalemia and stuff like that. Norepinephrine and epinephrine, if you give them an overdose, they're going to give you the sympathomimetic effect. Okay, so the difference between sympathomimetics and anticholinergics: sympathomimetics are sweaty, anticholinergics are dry. Sympathomimetics, usually when they have agitation, their agitation is really bad. They're aggressive, they can hit you. The anticholinergic, usually they're not aggressive, but they're annoying. They might fall off the bed, they might hurt themselves. Okay, both treated with benzodiazepines. The agitation of both conditions, we always treat agitation in toxicology with benzodiazepines. We don't like to use antipsychotics because they have side effects, and because the medication that the patient took may have an effect that antipsychotics may exacerbate, and the antipsychotics may worsen hyperthermia. So we like benzodiazepines in toxicology. It's usually a correct answer when there is agitation and even for hypertension. Okay, so supportive care with benzodiazepines, fluids, you cool them, you treat seizure with benzodiazepines, and the next agent, if benzodiazepines doesn't work, we use barbiturate. If barbiturate doesn't work, we use propofol. We do not use phenytoin. We do not use any sodium channel blockers to treat seizure from poisoning, because seizure from poisoning is not epilepsy. It's increase in stimulants compared to depressants. So you have increased stimulatory neurotransmitters and decrease inhibitory neurotransmitters, and that's why you get seizure in toxicology. So you treat it by giving more inhibitory neurotransmitter, which is GABA, the most abundant inhibitory neurotransmitter in the body. Benzodiazepines stimulate GABA release, so that's why we use them. All right, so avoid phenytoin. In sympathomimetics, it's commonly said that you need to avoid beta blockers because you have two types of beta receptors, beta 1 and beta 2. And when you have sympathomimetic effect, both are stimulated. Beta 1 will cause tachycardia and beta 1 will cause tachycardia, and beta 2 actually will cause vasodilatation. So tachycardia and hypertension from tachycardia from beta 1, hypertension from stimulation of the alpha receptors, but stimulation of beta 2 receptors may reduce the hypertension a little bit. So when you give beta blockers, you block the beta 2s, so you get just hypertension without the vasodilatory effect of beta 2, and that's why they say avoid beta blockers, use alpha blockers, like phentolamine. This is not a big deal, but it's maybe good to know just if someone asks you. Okay. All right. Next. So you probably know about this, narcotics or opioid toxidrome. Here patients will come with what? The most important clinical feature of opioid toxicity is decreased respiratory rate. And that's what kills the patient. They stop breathing and they die. So you have to recognize this. Most opioid will give you decreased level of consciousness with that. And a lot of them will give you pinpoint pupils or small pupils, but not all of them. Okay, so watch the respiratory rate if you're suspecting opioid toxicity. And they can cause hypotension, they can cause hypothermia and hyporeflexia. But the most important to watch for is respiratory depression. And that's what kills the patient. If they have respiratory depression, we give them naloxone. Naloxone is the antidote for opioid toxicity. Opioid like morphine, hydromorphone, heroin, fentanyl, okay? So typically when we see a patient in the emergency with reduced respiratory rate, altered level of consciousness, we try naloxone and see if it helps. We start with a small dose and then we increase the dose as we go. I don't want you to remember any doses from this lecture. Just remember what to do. And most importantly, how to recognize these, and then you can ask for help and you can treat the patient appropriately. All right. Sedative hypnotics, these are alcohol, benzodiazepines, many of the antidepressants and antipsychotics can give you sedation effect, like olanzapine, for example, Seroquel or quetiapine. So these are sedatives. They're not narcotics, and they cause, because they're sedative, they cause decreased level of consciousness. In large doses, they can cause apnea or respiratory depression. They cause usually ataxia and slurred speech. If you want to remember sedative hypnotics, just imagine someone is drunk alcohol, and they're drunk now. That's what sedative hypnotic is. The problem with sedative hypnotics is if you mix them. If you mix them, it's a problem, because then you get severe respiratory depression to the limit that the patient may need intubation. You can get hypotension, and the patient may go into cardiac arrest if they mix sedatives. So how do we treat these guys? Usually supportive care. So as I mentioned, benzodiazepines, antipsychotics, usually due to the antihistamine effect, because all antihistamines, non-selective antihistamines cause sedation, and then alcohol due to GABA stimulation, same as benzodiazepine. So we treat them with supportive care. The most important is ABC. So you intubate them if they are not protecting their airway or not breathing, they have apnea, then you intubate them and breathe for them. You give them oxygen, you give them fluids to treat their hypotension, and you can use flumazenil. It's an anti-benzodiazepine. It's a benzodiazepine receptor antagonist. The problem with flumazenil is if the patient is a chronic user of benzodiazepine, they're gonna have withdrawal and they can have seizure. And when they have seizure, you wanna treat them, you give them benzodiazepine, it may not work, okay? So we usually give it, if we give too much benzodiazepines, then we can reverse it with flumazenil. But if the patient come with sedative syndrome, we treat them with supportive care. We avoid it because we wanna avoid the withdrawal. So it's basically, we use it when we make a mistakes most of the time, or in pediatric patients who we know they're not chronically abusing benzodiazepines or sedatives. In general, it's not as good as physostigmine safety is higher than flumazenil, but there is literature coming to say that flumazenil is safe when you know how to use it. All right. This is a summary of the toxidromes that we spoke about so far. So anticholinergics, remember, their heart rate is fast, their temperature can be high, their pupils are dilated, they have reduced bowel sounds, and the most important is their skin is dry. Okay, they look like the sympathomimetics here because they both have tachycardia, they may have high blood pressure, both of them more in the sympathomimetics, and they have a hyperthermia, they have dilated pupils, but here the bowel sounds are increased, but you might not, this is not a reliable feature. What's reliable is the sweating. They will be sweating, while the anticholinergic, they will be dry. This is a good feature to differentiate the two. Okay, cholinergic, we spoke about it. We said secretions everywhere, okay? The pupils might be small. They may have bradycardia, depending on what they ingest exactly, but they may have tachycardia also. And their bowel sounds are increased usually, very large, very loud bowel sounds, and they have increased secretions from everywhere, including sweating. Opioid, the most important is respiratory depression. That's why you have the big arrow here. But they also may have bradycardia, especially with drugs like methadone. They will have most of the opioid will cause pinpoint pupil, but not all of them. Meperidine, tramadol may not cause small pupils. Okay. Sorry, I'm pointing to the wrong. So small pupils, they may have hypothermia. Their skin may be normal or dry. Okay. Sedative hypnotics, they're basically sleeping, comatose. Their vital signs are usually normal unless they mix sedative. They may have bradycardia, they may have respiratory depression, they may have hypotension even, and dry skin. So this is just a short summary of what we spoke about. So now let's talk about serotonin toxicity. So serotonin is a neurotransmitter that makes you happy, right? So we use it in antidepressants. Some antipsychotics have serotonin. Usually the patient is fine if they are only taking one drug that increases serotonin. If they take two medications that increase serotonin, then they may go into serotonin toxicity. Just remember, serotonin toxicity is very similar to sympathomimetics, okay? Except that they're, the sympathomimetics usually, they're more aggressive than the serotonin toxic patients. And you have a hint from the history that the patient is taking serotonergic agents. That's why they get serotonin toxicity. They will have dilated pupils, they will have agitation, they will have hyperreflexia, they will have clonus. Clonus is a very good feature for serotonin toxicity. You can see ocular clonus where the eye is moving in all directions. It's not like this nystagmus where the eye moves in a specific direction. In clonus, the eye is jerking everywhere. And then you can get limboclonus as well, okay? They usually either overdosed or mostly, not even single agent overdose usually doesn't cause serotonin toxicity. It may, but not common. But 2 serotonergic agents, not in overdose, can cause serotonin toxicity, just in therapeutic doses. All right. So excessive activation of the serotonin receptors causes the serotonin toxicity, both in the CNS and periphery, because a lot of your serotonin receptors, actually the majority of your serotonin receptors are in the GI tract. And that's why when you prescribe SSRIs, some patients may come with diarrhea and GI symptoms. It's just because they are getting a little bit of serotonin stimulation in the GI tract. So usually, most commonly from drug-drug interaction of 2 serotonergic agents. How do we treat them? Again, supportive care. You will hear me saying supportive care all the time. So ABCs, you protect their airway, you give them oxygen, you give them fluids, and benzodiazepines for agitation. So supportive care and benzodiazepine are your friends in toxicology, okay? Cyproheptadine is an anti-serotonergic agent. It's not a great medication. Supportive care and benzodiazepines are the way to go. If you want to use cyproheptadine, consult a toxicologist for that, but just know it for your exam stuff like now and in the future, but it's not very, very important clinically. All right. Commonly, you guys get taught that serotonin and neuroleptic, they look alike. They're actually very different, okay? So for serotonin toxicity to happen, you need drugs that increase serotonin. While for neuroleptic malignant syndrome, you need drugs that increase, that blocks dopamine, like antipsychotics, like haloperidol. They both have increased muscle tone, cause increased muscle tone, the serotonin and neuroleptic. They both may cause hyperthermia. They both may cause autonomic instability. But the difference is, first, the agents are different that causes them. If you are taking antipsychotics, you're more likely to get NMS, but you're not going to get NMS if you're taking antidepressant. There's no way. You have to be taking something that blocks the dopamine receptors. And clinically, when you see them, you see this like a metal. It's because the patient is in the bed, they're rigid, they're not moving at all. While if you look at the serotonin, I'll show you the picture again. Oops, why does it go previous? Look at the serotonin, the patient is trying to get off the bed. They're hyper in the bed. So that's a big difference that clinically can easily differentiate between the two, okay? Okay, so fever, altered mental status, they can have leukocytosis, they can have tremor, both can have serotonin and neuroleptic malignant syndrome can have tremor. Usually CPK is elevated more in neuroleptic malignant syndrome, and the rigidity in neuroleptic is like wood. They're not moving at all. Their limbs are very rigid. Okay. So excessive dopamine blockade, you block the dopamine receptors, usually result of initiation of antipsychotic or increasing the dose. Okay, so the patient just started on antipsychotics and they're sensitive to them, or the dose was increased recently. The other difference between serotonin and neuroleptic malignant syndrome, serotonin comes in very fast, like within a day or two, they get serotonin toxicity after starting the agents, while neuroleptics, they usually need multiple days to weeks to start. So how do you treat them? You stop the offending agent, the antipsychotic. Same for serotonergic agent, you stop the offending agent. You do good supportive care, fluids, cooling, ABCs, fluids, cooling, and then bromocriptine, which is a dopamine agonist, because we give the reason for the neuroleptic is dopamine blockers. We give dopamine agonist, which is bromocriptine. In severe cases, when bromocriptine is not enough, we use dantrolene. It's going to help the rigidity and the hyperthermia. Again, for both, you stop the offending agent. For serotonin, usually when you stop the offending agent, within 24 hours, they're back to normal. For neuroleptic, it develops slowly and resolves slowly. It takes days for them to go back to their normal. Okay. All right. So this picture will give you the idea of how you see them clinically. Look at the serotonin guy. He's trying to move out of the bed. He hit the doctor. Well, the neuroleptic guy is like a metal. See the bite there? So he's not moving at all. He's rigid there. Okay. He took haloperidol while this guy took 2 serotonergic agents. This is an monoamine oxidase inhibitor, and this is an opioid which can increase serotonin release. That's meperidine. All right. Okay. And you look here, what time is the circus coming? Here it says in a few minutes. That means it starts rapidly after starting the medication, the serotonergic agent. Here they say it's coming in 30 days because it's a slow start. Okay, I hope this picture helps you differentiate the two. When you go to see them clinically, it's actually very nice to visualize this. All right. So in general, when in toxicology, we just mentioned stuff, how to manage, but I will repeat them back again. So you protect their airway. Very, very important. This is more important than giving the antidotes, okay? Airway protection, all right? And you make sure they're breathing well, or you breathe for them, you ventilate them. You give them naloxone if they're opioid overdose, and so on. And then circulation, if they're hypotensive, you give them fluids, and if fluids is not enough, you give them vasopressors or inotropes to improve their cardiac function. And then A, B, C, D. In trauma, you see D is disability. Here it's disability, but also, so you're gonna look for any signs of stroke or anything else like causing disability, and trauma as well. And then, but very important for toxicology is to look for hypoglycemia, because many medications can cause hypoglycemia, like oral hypoglycemic agents, insulin, even some antidepressants in big overdose can cause hypoglycemia. And that's what would make the patient altered. And unless you fix their hypoglycemia, you're not gonna fix anything. They're actually gonna get worse, they're gonna seize, and then they're gonna die if they don't fix hypoglycemia. So if you see a patient in the emergency room with any alteration in the level of consciousness, you always, always, always check the glucose. Even if you see a patient who looks like they're having a stroke with one side weakness, they can be hypoglycemic. So it's the only metabolic abnormalities that can give you focal deficit. So always check the glucose before calling a stroke code, or when you see any patient who's altered. Then seizure, we need to treat seizure rapidly in toxicology with benzodiazepines, because seizure causes acidosis, and then it's very difficult to treat the patient if we delay the treatment of seizure. Plus, we have to anticipate seizure with some medication. We know that antidepressant, antipsychotics, some drugs of abuse like cocaine can cause seizure. So we have to be ready for treating that. And then the other D is decontamination. Do you guys know what decontamination is? I think we're doing okay in terms of time. So decontamination is removing the drug or the toxin before it reaches the systemic circulation. So if the toxin is in the skin, like insecticide, like organophosphate, then you wash their skin, you remove their claws, you make sure that you have removed all the toxin from their body. And if it's ingested, then you can give activated charcoal for some toxins where activated charcoal can bind, and that will prevent the absorption. Or sometimes in rare situation, if the patient took life-threatening overdose of a medication that we don't have an antidote, then we can do gastric lavage. If it's within 30 minutes to 1 hour, we could use that. Whole bowel irrigation for some drugs that doesn't bind activated charcoal, and we still think that they are in the gut, so we can wash their gut. And then we look for antidote. Do I have an antidote? So hypoglycemia antidote is glucose. Opioid, like morphine, the antidote is naloxone, and so on. We'll talk about antidote later on. And then good supportive care. Very good supportive care is very important. Patient won't survive, even if you give them the antidote, if you didn't give good supportive care. So airway, always assist the airway before everything and protect it. If the patient ingests caustics and they are having striders, then they're having trouble with airway. They need intubation early on before the swelling gets really bad and then you cannot see. Yes? Is someone trying to say something? Okay. So protect their airway, it's a priority. Sometimes they are overly sedated, very badly sedated that they cannot handle their secretions. They need intubation because they're gonna aspirate. And sometimes they're vomiting and altered, so you need to protect their airway because they're gonna aspirate the vomit. Okay, so this is an airway of someone who ingests corrosives. They come early, there is minimal swelling, you can see the cords. Then you wait a little bit, the swelling gets worse, and you should have intubated at this stage or at least this stage. When it goes to this, where there's a lot of swelling, you cannot see the cord, you may not be able to intubate the patient. And even later on, you won't see anything. Here you see just a little bit of the cord, you see the epiglottis, but later on you won't see anything, and the patient may die or may need, unless you put a surgical airway. Okay, that's why assessment of airway always take priority. Respiratory rate is very important, like we said in opioid and in other toxins. Sometimes the patient is breathing very fast because they have metabolic doses from the toxin. So we need to make sure that if we intubate them because they're agitated or whatsoever, that we put them in the ventilator with a respiratory rate that matches their previous respiratory rate, because we need to keep the minute ventilation. Because we want to watch CO2. Because if they have metabolic acidosis, they have low bicarb, and then you add high CO2, then the acidosis gets worse and they kind of go into cardiac arrest. Okay. Yeah. Okay. All right. So it's usually a sign in toxicology. It's either direct stimulation of the respiratory center like aspirin, or a sign of metabolic acidosis. They're trying to wash out CO2 to compensate for the metabolic acidosis. Sometimes organophosphate, because they cause a lot of secretions, they have tachypnea, and that's another reason for you to consider atropine, but usually you will see a lot of secretions. And then stimulants, they cause increased respiratory rate by themselves, and they also cause metabolic acidosis. Hypotension, usually we treat it like anything in emergency. We start with fluids and then inotropes and vasopressors. In toxicology, if we see hypotension and widening of the QRS complex in the ECG, we give them sodium bicarb, because it corrects the acidosis and also give them a sodium load that will act on the sodium channel and overcome the blockade. Digoxin specific antibodies, if they're hypotensive from digoxin overdose or chronic toxicity, then digoxin antibodies will help their blood pressure and will help their respiratory rate. Okay, that's for circulation. If hypertension in toxicology, typically we try to treat the cause. So if they have sympathomimetics or they are hypertensive because they're agitated, benzodiazepines is usually our first line, because it will calm them down, it will cut their sympathetic tone, and their pressure will improve. If they don't improve, we'll try to use an alpha antagonist like phentolamine, or we may use nitroglycerin. We try to avoid beta blockers because we're gonna have just alpha effect, and which is severe vasoconstriction, and we use the beta-2 effect, which is vasodilatation. Always, every patient who come with intoxication, overdose, they need an ECG, okay? And if it's an intentional overdose, they need an acetaminophen level, and we'll talk about that later. Okay, just want you to know that sodium channel blockers cause wide QRS. This is a normal QRS. This is, you see how wide it is? The QRS is from here to there. So that's wide. And if this continues to get wider and wider, they get into ventricular tachycardia like this. If you have potassium channel blockers prolong the QTC. The QTC, the normal is here, and it starts getting longer, and then until you get the next QRS, and then the QRS comes over the T, and then you get torsade, which is here. So if you have sodium channel blockers, we give sodium bicarb. If you have potassium channel blockers causing prolonged QTC, we give magnesium. Just for your basic knowledge, it's not. Okay, hypoglycemia, you give them glucose to correct it. If they are not awake, you give them IV glucose. If they're awake, you can give them juice and then food, which is going to last longer than the IV glucose. But if they are not awake, if you give them food, they can aspirate. So you give them IV glucose. Okay, seizure, always treat with benzodiazepines as first line. Second line is barbiturate. And think of pyridoxine if the patient is in isoniazide or has isoniazide at home. This is a medication for TB, and it causes refractory seizure. Unless you give them pyridoxine, it's not going to stop. Phenytoin is not good for toxicology. It's actually contraindicated because it's a sodium channel blockers, and sodium channel blockers in overdose causes seizure. You don't give them sodium channel blocker to treat the seizure. We give them sodium bicarb and we give them benzodiazepines. So no phenytoin for us. Phenytoin is not a friend of toxicologists, okay? So why not phenytoin? Because it's a sodium channel blockers and you need epileptic focus for phenytoin to work, okay? You need the sodium channels to be in a certain state. Drug-induced seizure is due to imbalance between excitatory and inhibitory neurotransmitter. So because there is increased excitation, we treat it by giving inhibitory neurotransmitters, which is GABA through benzodiazepines or propofol or whatever, okay? So phenytoin may cause worsening of the seizure due to sodium channel blockers, but most of the time it's not going to work. That's why we don't like it for toxicology. All right. Hyperthermia, always treat it aggressively because patient who has hyperthermia from toxins like sympathomimetics, they're going to die. It's a sign that their mortality is really high. So cool them very aggressively, give them fluid, cool fluid, and it's not fever, so paracetamol is not going to work. It's not the treatment. The treatment is cooling. All right. Now, I took more than what I wanted to take in this lecture, but it's okay. We're going to compensate with the other one, inshallah. So this is the approach to your toxicology patient. And if you follow this, you will impress your emergency doctor because they like people to be organized and they like to treat life-threatening stuff first. So if the patient has issue with the airway, you protect their airway. If they have issue with the breathing, you help them. You breathe for them, you ventilate them, or you give them naloxone if it's opioid overdose. Circulation, if they are hypotensive, you need to correct it right away. You give them fluid, vasopressors, okay? Hypoglycemia has to be fixed right away, IV glucose, oral glucose if they are awake, seizure, benzodiazepines, 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 and treat hyper and hypothermia, warn them if they are cold, like barbiturate overdose, or if they are hyperthermic, which is you're gonna see more in Saudi Arabia, so you have to cool them, okay? You can put ice packs in their groin, axilla, give them cool fluid, and make sure that they are not overly covered. You can give them, you can spray them with water and put a fan to cool them. So that's resuscitation. That's how you stabilize your patient. And then you go to specific risk assessment. So the patient doesn't need resuscitation, A, B, C, D are okay, then you go to specific assessment. You ask them what they took, what's the agent, is it paracetamol, is it aspirin, what kind, is it extended release or immediate release, and then you ask him how much you took, and then because you want to calculate the dose per kilogram, how much did you take according to your weight, because a dose that might kill a child is different than a dose that might kill an adult. Adults can tolerate larger doses because they have larger weight. And very important to know the time since ingestion, because some toxin may not cause effect right away, like paracetamol. You might not see anything initially. So you need to know the time of ingestion. Also, you need to know it because you're going to draw it in the nomogram, and we're going to talk about that. And also to know when the symptoms going to start, because let's say you took extended release calcium channel blockers, it's going to take 12 hours to develop the symptoms. And these patients cannot go home because they're going to go home and they're going to die after 12 hours. So that's why it's important to know the time of ingestion and know whether the drug is immediate release or extended release. And then you need to know if they have symptoms and monitor their clinical course. Patient factors are important because someone with heart failure, they're not going to be doing well if they overdose on a cardiotoxic medications, okay? So if they have renal failure, they are not going to be able to clear lithium, so they're going to need dialysis. So patient factors are very important. And then good supportive care. You save lives by giving good supportive care, making sure the ABCs are okay. this will help the patient more than just thinking of the antidote. Then we do the investigations. Everybody in toxicology get a 12-lead ECG, and for every intentional overdose, we get paracetamol level. In pediatrics, we get it only if we have a history or it's intentional. In adults, mostly if it's intentional, we get paracetamol level. Sometimes pediatric accidental overdose, you don't need to get paracetamol level. Decontamination, if they come early on, you clean. If there's something on the skin, you wash their skin. You remove their clothes. If there is a toxin on the sprayed on them or on their clothes, and then if it's still within a reasonable time that you think the drug is still in the stomach, you can give them activated charcoal. If it binds to activated charcoal, we'll speak about that. And then you try to see, is there a way to get this toxin to be excreted fast, which is enhanced elimination. So decontamination is removing the drug before it gets to the blood. Enhanced elimination is once the drug is already absorbed, how can we get rid of it faster? And then we give antidote, which is something to antagonize, to act against the toxin, okay? And then we think about disposition. Can this patient go home? Can they go to the hospital floor, or they need to go to ICU, or they're fine, but they need to go to psychiatry because they took an intentional overdose. All right. I think I'm gonna take more time in this lecture from the other one. Okay, decontamination. What I want you to remember from decontamination is no ipecac. Induced vomiting is bad, okay? Even putting the finger on the patient's mouth to induce vomiting is bad because it can cause injury. Gastric lavage is only for life-threatening toxins that doesn't bind to activated charcoal, and we don't have a good antidote. If you want to do gastric lavage, you have to call the poison center. You have to speak with a toxicologist because there is risk of perforation, there is risk of aspiration, and you get in trouble. Activated charcoal is the thing that's commonly used. Again, it has advantage and disadvantage that we'll speak about soon. And then whole bowel irrigation is when you give them polyethylene glycol, you give it by mouth until they, what comes in the mouth is the same as what comes from the rectum. So you clean their bowel just like they're going for endoscopy. All right, so ipecac that causes vomiting is out. You don't use it. If you use it, you know you're wrong. Single dose activated charcoal, you give them 1 gram per kilogram of activated charcoal if they come within 1 hour of ingestion and they have normal mental status and you're not expecting them to seize right away. So if they're stable, you can give it, but it doesn't bind to metals and ions. So iron, lithium, potassium, these all metals and ions does not bind to activated charcoal. So it's useless, you don't use it. Hydrocarbons, because they don't bind to activated charcoal, and also hydrocarbons are okay if they are ingested, but it's a disaster if it's aspirated. So if you give them activated charcoal and they vomit and aspirate, you change a patient from a stable patient to a sick patient, okay? Corrosives, because they can have perforation, and then the activated charcoal can go to their mediastinum, can go to their peritoneum, and then you get peritonitis, mediastinitis. It's really bad. Okay, plus these patients may need intubation, and when you go to intubate them after activated charcoal, you see nothing but black. This is activated charcoal, it's really black. Alcohols, because alcohols are rapidly absorbed, does not bind to activated charcoal, and cause alteration in mental status. So if you give them activated charcoal, it's gonna go to their lungs, and they're gonna die from aspiration pneumonia, okay? So activated charcoal is contraindicated for anyone with decreased level of consciousness, anyone who's seizing or at risk of immediate seizure should not get activated charcoal. Anyone who could aspirate should not get activated charcoal. So usually, drug that bind activated charcoal, if it's less than 1 hour, if it's large or massive overdose, and activated charcoal can bind it, then, and the patient is stable and can take it, then you can use it. Otherwise, you can use it. Then if any of these questions is no, then you do not give it activated charcoal. The benefit of activated charcoal is small compared to the risk. So if you're not sure, don't give it, call the poison center and get advice. So if it's prolonged more than 1 hour, if it's a simple overdose, that's not dangerous. That activated charcoal may be more dangerous than the overdose. If activated charcoal does not bind to the drug, then there is no point of giving it. And if the patient is not stable or not willing to take it, then you shouldn't give it. These are drugs that doesn't bind to activated charcoal. Pesticides, because they're usually liquids, they get absorbed fast. So that's dangerous to give them activated charcoal also. Heavy metals, we talked about this. Alcohols, rapidly absorbed, does not bind and cause altered mental status. Iron is a metal. Lithium is a metal, and iron too. So it's not going to bind to activated charcoal. Solvents are stuff that can cause aspiration pneumonia and usually rapidly absorbed. So you should not give activated charcoal. Polyethylene glycol, this is polyethylene glycol. This is what the gastroenterologists use to clean the bowel before endoscopy. We use it if we think that the gut still has drug and we think that the amount is enough to cause significant toxicity, then we give them this. We give them 2 liters per hour in adult until clear fluid comes from the rectum. That means their bowel is clean. There is no more drug in the bowel. Okay, we use it usually for highly toxic substances that doesn't bind activated charcoal when supportive care is not enough. A good example of this, and you're going to see this most of the time, you're not going to see whole bowel irrigation in other medication. Mostly you're going to use it for iron, and usually a big dose of iron, more than 60 milligram per kilogram. For extended release calcium channel blockers or extended release potassium, lead poisoning sometimes, and body backers. These are drug users or drug dealers usually that wrap the drugs into aluminum foils or condoms, and they aluminum foils and then condom on top of it, and then they swallow it to smuggle it, to get through the airports, to get through checkpoints. And these patients, if they come to the emergency, they either come with abdominal pain or one of the backs have ruptured, then you do an X-ray, you will see a lot of bags in their abdomen. If they have no symptoms, you can use whole bowel irrigation to get rid of it. If they have symptoms, then it's dangerous to give it because that means the back has ruptured and they need surgery to remove it. The problem with this, again, you're giving so much fluid, they can get aspiration and they can get nausea and vomiting. And if they have bowel obstruction, they will for sure vomit and aspirate. Sometimes we use more than 1 dose of activated charcoal. This is very uncommon. It's only for these drugs that have extensive enterohepatic circulation, because the drug gets absorbed, goes to the liver, and secreted from the liver to the gut again, enterohepatic recirculation. So you try giving another dose of activated charcoal that you catch the drug. When it comes back from the liver to the gut, you catch it here, you absorb it to the charcoal and get rid of it in the bowel, in the stool, instead of it being reabsorbed again. Carbamazepine is a common example, dapsone, quinine, and theophylline, and phenobarbital. Okay, so enhanced elimination, usually multi-dose activated charcoal. We said elimination is after the drug is absorbed, we want to get rid of it from the body. It's not decontamination. Decontamination is before it's absorbed. And the techniques for enhanced elimination is multi-dose activated charcoal, urine alkalinization to improve excretion, and this will explain in the aspirin lecture, hemodialysis. Forget about the hemofiltration and stuff because this is not available in most hospitals. Hemodialysis, you dialyze the drug, okay? And forget about this. So multi-dose activated charcoal, urine alkalinization, and hemodialysis are the stuff that you're gonna see. And mostly urine alkalinization and hemodialysis. But these are the ways to enhance elimination. Last thing in this lecture is the antidote. I want you to remember this very well because you're gonna see a lot of acetaminophen overdose. Yesterday, I saw a patient who came with liver injury from acetaminophen overdose because she came late, and we gave her N-acetylcysteine. We're gonna talk about that in the acetaminophen lecture. Benzodiazepines, the antidote for it is flumazenil. We don't give it to everybody. We give it usually to the patients that we give benzodiazepine and we give them too much, and now we need to reverse it. We don't give it to everybody because we might induce withdrawal of benzodiazepines, okay? Beta blockers, glucagon is one of the antidotes that's mentioned, but high dose insulin and glucose is better. Cardiac glycoside, which is digoxin, an example, you give digoxin antibodies. Venomous snakes, you give the antivenom. Cyanide, we give hydroxycobalamin, is the antidote for it. Cyanide is usually the cases of cyanide that we see it in fire enclosed space where there is plastic. There will be hydrogen cyanide gas, and then when the patient inhale it, they lose consciousness, they become hypotensive. And this time, when patient comes like that, hypotensive, loss of consciousness, and high lactate, you give them hydroxycobalamin. You don't wait. You cannot confirm cyanide because they're going to die if you don't give it. The risk from it is very small, but the benefit is huge. So fire in a closed space, or someone who works in a lab and has cyanide and ingested cyanide to kill themselves. But usually you're going to see fire victims. Ethylene glycol is toxic alcohol, and fomepizole is the antidote. We'll speak about that in details. Iron, the antidote for iron is defuroxamine. Defuroxamine does bind to iron just like what activated charcoal does with other drugs, but activated charcoal doesn't bind to iron. Defuroxamine chelate iron, binding to it and excreting it out. It binds to it in the blood and get it excreted from the blood. Find a complex with iron, it formed a complex with iron and then get excreted in the urine. So it adsorbs to it. It hugs it. Sorry, again. Isoniazide, overdose, pyridoxine is the antidote. Methanol, fomepizole, just like ethylene glycol, it's fomepizole. Methemoglobinemia, we give methylene blue. Blue patients with methemoglobinemia, they come with cyanosis, they're blue. Blue patients, we give them a blue dye, methylene blue. Opioid, naloxone, you all know that. Organophosphate, which causes a cholinergic toxidrome, we give them atropine until we dry their secretions. And if we know it's organophosphate, we give them pralidoxine. This is going to be another talk maybe, or later on when you specialize in another subspecialty, you'll get details of this. Sulfonylureas, which is oral hypoglycemic. The treatment is glucose because they get hypoglycemia, and you give them octreotide to inhibit insulin secretion because sulfonylureas cause insulin secretion. Octreotide inhibit the insulin secretion, okay? In addition to giving them glucose because they're hypoglycemic. Excellent. Guys, this is all for this lecture. I'm sorry, I know it's long, but we started 10 minutes late. If you have any questions, you can ask. I'm gonna just share the other lecture.